Hey everyone, this video will speak about Bhore Committee. Introduction. Health planning in India is an integral part of national socio-economic planning. The guidelines for national health planning were provided by a number of committees dating back to the Bhore Committee in 1946. These committees were appointed by the Government of India from time to time to review the existing health situation and recommend measures for further action. The recommendation of these committees, which are important landmarks in the history of public health in India. The Alma Ata Declaration on Primary Health Care and the National Health Policy of the government gave a new direction to health planning in India, making primary health care the central function and main focus of its healthcare delivery system. The goal of health planning in India was to attain health for all by the year 2000. During the pre-independence era, to improve the preventive and promotive and curative health service of country, a national planning commission was set up by the Indian Nation Congress in 1983. The rulers of that time, the British Empire, realized that the importance of public health and instituted the Health Survey and Development Committee in the year 1943 under the chairmanship of Sir Joseph Bore. The committee was conducted to survey the existing position regarding the health condition and health organization in the country and to make recommendations for the further future development. The committee, which had among its members of some of the pioneers of public health, met regularly for 2 years and submitted in 1946 of its famous report, which runs into 4 volumes. The committee put forward for the first time comprehensive proposal for the development of national health programs of health services for the country. The committee observed if the nation's health is to be built, the national health program should be developed on a foundation of preventive health work and that such activity should proceed side by side with those concerned with the treatment of patients. Recommendations of Bhore Committee. Integration of preventive, promotive and curative services at all administrative levels. The development of PHCs for the delivery of comprehensive health services to the rural India. Each PHC should cater to a population of 40,000 with a secondary health center to serve as a supervisory coordinating and referral institution, which means it should have 2 medical officers, 4 public health nurse, 1 nurse, 4 midwives, 4 trained nurses, 2 sanitary inspectors, 2 health assistants, 1 pharmacist and 15 other class 4 employees. In the long-term plan, that is 3 billion plan, the PHC should have a 75-bedded hospital for a population of 10,000 to 20,000 and secondary units with 650 bedded hospitals, again regionalized around district hospitals with 2,500 beds. Long-term plan recommended by Board Committee at different levels. Primary unit, that is first year level. Every 10,000 to 20,000 population depending on density from one area to another. It should have 75 bedded hospital served by 6 medical officers including medical, surgical and obstetrical gynecological specialists. This medical staff would be supported by 6 public health nurses, 2 sanitary inspectors, 2 health assistants and 6 midwives to provide domiciliary treatment. At the hospitals, there would be a complement of 20 nurses, 3 hospital social workers, 8 ward attendants, 3 compounders and other non-medical workers. The 2 medical officers along with the public health nurses would engage in providing preventive health services and curative treatment at home of patients. The sanitary inspectors and health assistants would aid the medical team in preventive and promotive work. Preferably, at least 3 of the 6 doctors should be women. The 75 beds, 25 would cater to your medical problems, 10 for surgical, 10 for gynecological, 20 for infectious diseases, 6 for malaria, and 4 for tuberculosis. This primary unit would have adequate ambulatory support to link it to the secondary unit when the need arises for secondary level care. Each province was given to autonomy to organize its primary units in the way it deemed most suitable for its population, but there was to be no compromise on quality and accessibility. And next secondary unit, that is second tier. The secondary unit would be a 650 bedded hospital having all the major specialties with a staff of 140 doctors, 180 nurses and 178 other staff including 15 hospital social workers, 50 ward attendants and 25 compounders. The secondary unit, besides being a first level referral hospital, would supervise both the preventive and curative work of the primary units. Note, the 650 beds of the secondary unit hospital would be distributed as follows: medical 150, surgical 200, obstetrical and gynecology 100, infectious disease 20, malaria 10, tuberculosis 120 and pediatrics 50. Totally, it should be 650 bedded hospital. And third, we have district unit, that is third tier. Every district center would have a 2500 bed hospital providing largely tertiary care with 269 doctors, 625 nurses and 50 hospital social workers and 723 other workers. The hospital would have 300 medical beds, 350 surgical beds, 300 obstetrical and gynecology beds, 540 tuberculosis beds, 250 pediatric beds, 300 leprosy beds, 40 infectious diseases bed, 20 malaria bed and 400 bed for mental diseases. A large number of these district hospitals would have a medical colleges attached to them. However, each of the three levels would have functions related to medical education and training including internship and referral courses. Other recommendations of Bhore Committee: 3 months training in preventive and social medicine to prepare social physicians, special emphasis on preventive work, that is integration of curative and preventive services, village health committee consisting of 5 to 7 individuals for procuring the active participation of the people in the local health program, intersectoral coordination. This document laid the utmost emphasis on primary health care. It needs no emphasis that primary health care was later on recognized as the key strategy to achieve health for all by 2000 during Alma Ata conference. The Bhore Committee was based on the allopathic system of medicine, the traditional health practices and indigenous system of medicine prevalent in rural India, which had a great influence and were part of the socio-cultural milieu, were not included in the model proposed by Bhore Committee. Although the Bhore Committee's recommendations did not form part of a comprehensive plan for national socio-economic development, the committee's report continues to be a major national document and has provided guidelines for national health planning in India. Thank you.